E o assunto do momento é a imunoterapia, que foi tema de muitas aulas durante o ASCO, o ESMO, tanto desse ano como do ano passado, e também está sendo amplamente abordada aqui no 5º Simpósio Internacional do Grupo Oncoclínicas. Um dos palestrantes é o Dr. Ian Krop, que é professor associado de Medicina na Harvard, é médico oncologista e também diretor de pesquisa clínica no Dana-Farber. Ele comenta agora sobre câncer de mama e imunoterapia. Hi, doctor.
Hello.
Thanks for being here. It's a pleasure to have here sharing your experience with us.
It's my pleasure to be here.
And you had a presentation on immunotherapy in breast cancer. Mm-hmm. So I would like to ask you, why drugs that activate the immune system are so important in breast cancer?
Yeah, so we've known for a long time, many years, that the immune system, our body's immune system, is able to attack cancer cells. But for some reason, the cancer cells are able to suppress the immune system so that the immune system is not able to eradicate the tumor. About 5 years ago, it was realized that one way that the immune system is suppressed by the cancer is through a molecule called PD-1 and a related molecule called PD-L1. And so once that was realized, that is how the cancer suppresses the immune system, drugs were developed that block that PD-1, PD-L1 system. And when you block that system, it allows the immune system to activate and attack the cancer.
All right.
And that's been shown in melanomas, lung cancer, kidney cancer, to be highly effective treatment to just these drugs alone. When given to patients with these particular types of cancer, the immune system is able to activate and actually lead to significant improvements in outcome, even in patients who've had very advanced disease.
All right. And do we have any results so far that attest that immunotherapy is effective in breast cancer?
Right. So because of the data in these other cancer types, we are very interested in exploring how these therapies may work in breast cancer. So there have been a number of clinical trials, relatively small so far, that have looked at these PD-1 or PD-L1 inhibitors mostly in metastatic breast cancer. So far, the data have been somewhat disappointing, or at least modest in activity. So when these drugs are given by themselves in patients with metastatic breast cancer, and most of the data has been in triple-negative breast cancer, somewhere between 5 to 10, maybe 20% of patients have some response. The good thing is that when they have a response to these drugs, the response usually lasts a long time. And that's been seen in breast cancer as well as many other cancers. The problem, though, is that it's a relatively small percentage of patients who seem to benefit. And that's only in triple-negative breast cancer. And we thought that that would be the cancer that had the most activity because triple-negative breast cancer seems to be the most immunogenic. There seems to be more activity in patients who have not had a lot of chemotherapy already, and patients who seem to have more immune cells within the tumor. But overall, the amount of patients who seem to benefit has been relatively small when these drugs are used by themselves.
What can we do to make this use more widely?
Right. So that's the really important question. So we are concerned that the reason the immune system has not worked so well in most breast cancers is because breast cancer is a little different than cancers like melanoma, in that breast cancer does not have a lot of mutations in the DNA. And when you look under the microscope, there are not a lot of immune cells in the cancer. So it doesn't look like the immune system recognizes the majority of breast cancers. And so activating the immune system doesn't do that much if the immune system can't even find the cancer. So how do we think we may be able to get around that is by doing other therapies along with the immune therapy to try to improve the ability of the immune system to recognize the breast cancer, to make them more inflamed, more immunogenic.
What kind of therapies?
Right, so we've trying a number of different approaches. The one that seems the most promising right now is to add chemotherapy to the immune therapy.
Okay.
And we've had several small trials that have looked at that, some in the metastatic setting, and very recently a trial in early disease patients in the preoperative setting before patients have had surgery. And particularly in the preoperative setting, which is the only randomized trial, in that study, patients who had either triple-negative breast cancers or more aggressive estrogen receptor positive breast cancers were given standard neoadjuvant chemotherapy, an anthracycline and a taxane chemotherapy, either by itself or with a PD-1 inhibitor, pembrolizumab.
Okay.
And in that study, they looked at the percentage of patients who had complete elimination of their cancer in their breast when they had surgery. And in both triple-negative breast cancers and in estrogen receptor positive breast cancers, the percentage of patients who had elimination of their cancer, which we call pathologic complete response, essentially tripled, so 3 times higher if you got the immune checkpoint inhibitor with the chemotherapy compared to chemotherapy alone. And we think that that's very exciting because it does suggest strongly that if we combine chemotherapy with these checkpoint inhibitors, it will work on a greater percentage of patients. So right now, there's a number of clinical trials that are just getting started, both in the metastatic setting as well as in the adjuvant setting, comparing chemotherapy alone or chemotherapy plus a checkpoint inhibitor. And we're hopeful that that's going to be a successful trial.
And you are a research clinical director at the Dana-Farber. Are those studies being conducted there? What would be your personal experience?
Yeah, so we've been doing some of these trials since the first trials in breast cancer. And we have now a number of different trials going on. There's also some of these trials are being done internationally, so including in Brazil. The trials that we have at the Dana-Farber have been mostly combining immune therapies with either chemotherapy like we talked about, but also with other kinds of targeted therapies. And my personal experience has been, I think, pretty similar to what the overall data has shown, which is I have a few patients who've done very well with immunotherapy. Patients who I thought were going to have cancer that continued to progress, and yet with immune therapy, they had very long control of their disease and did not have any symptoms and did not have a lot of side effects from the treatment. But I had most of my patients, the immunotherapy has not worked very well, and that just further encourages us to come up with new ways to explore using immunotherapy in breast cancer. It has not been as easy in breast cancer as it has in some of these other cancers like melanoma, but we still feel very optimistic that eventually we will be able to get these immune therapies to work for a large number of our patients.
And I'm sure you're gonna make it.
Thank you.
Thank you for sharing your experience with us. Muito obrigada. Continuem acompanhando a nossa cobertura do 5º Simpósio Internacional do Grupo Oncoclínicas.